Symptomatic coronary artery disease can be divided into stable coronary artery disease and acute coronary syndromes. Asymptomatic coronary artery disease seldom present to the primary care physician and is often detected by a routine health checkup or preoperative evaluation. Stable coronary artery disease usually presents in the form of chronic stable angina. Following are the important causes of acute coronary syndrome. Atherosclerosis with plaque rupture or erosion leading to thrombosis, coronary spasm, coronary embolization, spontaneous coronary artery dissection, and coronary arteritis. Acute coronary syndromes could be either unstable angina or acute myocardial infarction. Acute myocardial infarction can be further subdivided into ST elevation myocardial infarction or STEMI and non-ST elevation myocardial infarction or NSTEMI, depending on the presence or absence of ST segment elevation on the electrocardiogram. The term non-ST elevation acute coronary syndromes or NSTACs comprise of NSTEMI and unstable angina. The difference between NSTEMI and unstable angina is the presence of evidence of myocardial necrosis in the former in the form of an elevated biomarker, usually cardiac troponin. Unstable angina is either rest angina or a recent change in the anginal threshold in effort angina. Thus, chronic coronary syndrome can become an acute coronary syndrome, usually by intervention of some precipitating factors like anemia, fever, infection, hyperthyroidism, and atrial fibrillation with fast ventricular rate. A combination of factors may work together, like atrial fibrillation with fast ventricular rate in hyperthyroidism. Change in the characteristic of the atherosclerotic plaque is often the reason for unstable ischemic syndromes. A plaque with lipid-rich core and a thin cap can rupture in response to hemodynamic stress. Clots can form in an ulcerated atherosclerotic plaque, which can cause sudden increase in the luminal narrowing. Alternatively, hemorrhage into the plaque can also enhance the luminal stenosis. If the lumen gets totally occluded, it usually results in an ST elevation myocardial infarction. Partial occlusions could cause either an unstable angina or non-ST elevation myocardial infarction. It may be noted that the former can progress to the latter. Typical ECG change in unstable angina is a horizontal ST depression, often in the inferior and lateral leads. Downsloping ST depression and T-wave inversions may also be noted in unstable angina. Occasionally, ECG can be normal in unstable angina. Risk is higher in those with ECG changes than in those without ECG changes. ST elevation during angina, returning back to baseline when angina subsides, is classical of Prince-Metals vasospastic angina due to coronary vasospasm. It may be noted that Prince-Metals angina is associated with obstructive coronary artery disease in 2/3 of cases. The prognosis is poorer in those with obstructive coronary artery disease. Acute coronary syndrome usually presents with history of prolonged central chest pain with or without specific radiation. Radiation of cardiac pain can be anywhere between the lower jaw and the umbilicus. A short history for assessment of risk factors can be made at the time of initial evaluation. Vital signs are recorded, followed by a quick physical examination. ECG should be obtained at the earliest, preferably within 10 minutes. If there is a reasonable certainty regarding the diagnosis of acute coronary syndrome, initial loading doses of aspirin, clopidogrel, and statin, often along with pantoprazole, are given. Acute coronary syndrome needs rapid hospitalization for further management. Certain high-risk features may be evident in acute coronary syndrome at presentation. They include accelerating symptoms in the last 48 hours, rest pain lasting more than 20 minutes, features of pulmonary edema, new onset mitral regurgitation, tachycardia, bradycardia or hypotension, age above 75 years, angina associated with shift in the ST segment, bundle branch block, sustained ventricular tachycardia, and elevated cardiac biomarkers. Biochemical markers in acute coronary syndrome. Important biochemical markers in acute coronary syndrome are troponin, high sensitivity, high specificity for myocardial tissue. CKMB, less tissue specific but useful in diagnosing reinfarction. Myoglobin, for rapid diagnosis. But current practice is to use mostly troponin because of high sensitivity and specificity. Advantages of troponin are that they are useful in risk stratification, have a better sensitivity and specificity than CKMB, can detect recent myocardial infarction, and facilitates the selection of treatment modality. Disadvantages of troponin are that the sensitivity is low in the early hours, needs repeat measurements at 8 to 12 hours if negative, and has limited ability to detect late minor reinfarction. Troponins are useful as a single test to efficiently diagnose non-ST elevation myocardial infarction. One should be familiar with the diagnostic cutoffs in the local lab. Delta troponin is the serial elevation of troponin over 1 or 2 hours. This needs 2 serial samples and delta troponin ranges for the lab technique should be available. Delta troponin is useful for the early rule-in, early rule-out strategy in the emergency department. Non-myocardial infarction causes of troponin elevation. Cardiac failure with myonecrosis, cardiac surgery, myocarditis, and renal failure are the important causes of troponin elevation other than myocardial infarction. Now these are classified under myocardial injury and have similar prognostic significance as troponin elevations due to myocardial infarction. Creatinine kinase MB fraction or CKMB. Advantages are that the assay is rapid, cost efficient, accurate, and detects early reinfarction. Disadvantages are the lower specificity and low sensitivity during early phase or later after onset of symptoms and for minor myocardial damage. Advantage of CKMB isoforms is for the detection of early myocardial infarction 3 to 6 hours after onset of symptoms. Disadvantages of CKMB isoforms are that the specificity profile is similar to that of CKMB and current assays require special expertise and are used predominantly as a research tool. Advantages of myoglobin are the high sensitivity and utility in early detection 2 hours after the onset of symptoms and hence most useful in ruling out myocardial infarction. Disadvantages of myoglobin are the very low specificity in the setting of skeletal muscle injury or disease, rapid return to normal, and it should not be used in isolation. Patients without biochemical evidence of myocardial necrosis but who have an elevated CRP are at an increased risk of an adverse outcome. Elevated levels of interleukin 6 and serum amyloid A have similar predictive value as CRP. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.